Hey guys, so welcome back to it. Today we are going to be talking about substance use, abuse, and addiction. This is going to be a little bit of a lengthier lecture, just as a heads up. So before we get into more of the clinical issues, let's just establish some basic information about drug use, abuse, and dependence, including defining those three terms and the differences. So drug use is simply just drug ingestion, regardless of the amount taken or its effects. Substance abuse is when substance use begins to cause problems, specifically problems relating to health and any aspect of health. So that could be a biological impact, a psychological impact, or social impact, or some combination. Drug dependence is when the mind and body have adjusted to the drug and now require it in order to function normally. So, in this instance, it's almost like drug use is necessary for normality versus being used recreationally for some type of high. Drug abuse causes more death and disability than any other preventable health condition. Today's focus is going to be more so on tobacco, alcohol, and specifically prescription drugs. Again, more specifically, even opioids. Although, first, we are going to talk about drug use and the physiological mechanics of that process a little bit more generally. Tobacco and alcohol use have increased recently in developing countries and have decreased in developed countries. As far as prescription drug patterns, this graphic here on the screen depicts the top 10 most abused prescription drugs as of the CDC's analysis of the situation in 2010. I'm going to highlight four of these categories for you guys here, specifically amphetamines, benzodiazepines, opiates, and cough syrup, basically, dextromorphin. So first up, we have amphetamines. Amphetamine salts in particular are the stimulant medication that are commonly prescribed to treat ADHD and narcolepsy. These drugs work by mimicking adrenaline, basically. Side effects include irregular heartbeat, panic, and heart failure. So those are some of the complications we could potentially see from abuse of this particular type of medication. Benzodiazepines are an anxiolytic, meaning they're an anti-anxiety drug, commonly prescribed to, of course, treat anxiety and tension. Side effects of abuse include drowsiness, loss of coordination, impaired thinking and memory, as well as depression. Opiates are a pain reliever that are, of course, prescribed to help alleviate moderate to severe pain. Side effects include respiratory arrest, coma, and death. Ultimately, these drugs can sedate the part of your brain that is responsible for breathing, which ultimately leads to those respiratory complications and death in certain situations. Dextromorphin or cough syrup is going to be this kind of additive that's used in many cold medicines. It's easy and cheap to abuse because it's easily accessible. A prescription isn't really needed. Some side effects of abuse of this medication include loss of coordination, high blood pressure, seizures, coma, and death. So let's talk a little bit about drugs in general in terms of how they work and how they're used. Ultimately, all drugs work once they are ingested into the body, and this can be done so in one of five ways: orally, rectally, via injection, inhalation, or absorption through the skin, which may happen in the case of like a nicotine patch or something like that. The type of administration plays a role in the physiological effects of that drug. For instance, injected or inhaled drugs contribute to more immediate effects than those drugs which may be taken orally. Within minutes of absorption, the drug is distributed to its action site, and specifically its action site within the brain. So the action site is going to be the area where the drug is taking effect. So, for example, marijuana goes directly to the cannabinoid receptors in the brain, and it's at that point that the psychoactive hallucinatory effects start to kick in. All substances and addictive behaviors, things like gambling, for instance, also play a role in increasing dopamine levels in the brain, which kind of gives you that high that you might even get from fairly benign behaviors like running. So, that dopamine rush, in addition to the physiological effect of a specific drug, are ultimately what contributes to the addictive nature of drugs. How quickly a drug gets to this action site depends on the rate of blood flow, blood pressure, and also how easily the drug is passing through various cell membranes and barriers. So, for example, water soluble drugs tend to stay in the blood, while fat soluble drugs tend to linger in fatty tissues such as the brain. Marijuana would be one such example of a drug that tends to linger more so in fatty tissues. Fat-soluble drugs also have a greater tendency to permeate the placental barrier, meaning the barrier between mom and a developing baby. And so, for that reason, those are really why those are the particular drugs that should be avoided during pregnancy. So, alcohol and tobacco are both fat-soluble drugs, and so those are drugs to be avoided during pregnancy. So, what happens once the drug gets to its action site in the brain? In a nutshell, based on what the drug is designed to do, the drug will either mimic the effect of a drug or it will block the effect, or the drug will either mimic the effect of a neurotransmitter, excuse me, or it will block the effect of a neurotransmitter. So, to understand this, we have to kind of back up for a moment and talk about neurotransmitters and how they work in order to understand how a drug would either mimic or block said neurotransmitter. So ultimately, when a neurotransmitter, something like dopamine, for instance, is released in the brain, what happens is an action potential or this kind of electrical activity starts with one brain cell or one neuron. And once that electrical activity runs the length of that neuron, what happens is the neurotransmitters are triggered into being released from one brain cell into the very, very tiny space between that brain cell and the next brain cell. These neurotransmitters or chemicals basically then dock onto the next brain cell, which kicks off the action potential, the electrical kind of energy again, that then travels down the length of that brain cell before chemicals are released again, which then travel to the next brain cell, and so on and so forth. So these neurotransmitters or these chemicals are basically released between brain cells in kind of like a domino style effect, almost like kind of handing the baton off, so to speak, to the next brain cell. And so, because of this, we need these very precise matchups between neurotransmitters and the receptor sites on the receiving neurons. So it's kind of like these intricate puzzle pieces that are designed to fit together. We've got the neurotransmitter and the receptor site, and they fit together perfectly like puzzle pieces. And so when the neurotransmitter, dopamine, for instance, docks on the designed receptor site, that's what kind of passes the baton off or kind of continues the process of dominoes, the impulse going from one brain cell to the next and ultimately having its effect. So, when we use drugs, they're ultimately going to these action sites, these receptor sites on these brain cells within different areas of the brain. And in general, as I mentioned, drugs can do one of two things. They can either mimic or block a neurotransmitter. An agonist is a drug that mimics a neurotransmitter. Agonists work because they're similar enough in structure to a neurotransmitter to be able to mimic its effects. So, kind of like the graphic is depicting on the far side of the screen, the pink portion labeled B, you can see that this drug is not a perfect match for the receptor site, but it's close enough that it can kind of fit in and in doing so mimic the effect of the chemical that's intended to dock there. So, for example, morphine mimics the action of endorphins because it's close enough to our body's natural endorphins that it can dock there, and in doing so, it can impact mood and pain sensation in the same way that endorphins naturally impact mood and pain sensation. And in fact, the term endorphin comes from the word morphine. Endorphin literally means endogenous morphine. And so, even though endorphins are our body's natural kind of version, they were named after morphine. Antagonists are similar enough to a neurotransmitter to occupy its receptor site, but they do not mimic the action. Instead, they block the neurotransmitter from being able to dock there and have an effect itself. So you can see that depicted on the bottom of this graphic in the yellow image labeled C. An example of this would be caffeine. Caffeine antagonizes adenosine, meaning that it sits there and it blocks the effect of adenosine. And adenosine is a chemical that impacts alertness and arousal. More specifically, over the course of the day, adenosine causes us to become more and more drowsy and less alert and aroused. And so caffeine doesn't really work per se by revving us up, so to speak. It works by blocking the effect of this neurotransmitter that's going to make us drowsy over the course of the day. In terms of clinical relevance, we have, in general, this single construct called a substance use disorder. I have the term substance listed on the slide in quotation marks because technically you wouldn't ever diagnose a person with a substance use disorder. Instead, you would replace the word substance with whatever the substance is that we're dealing with. So if someone was experiencing a problem with alcohol, they would be labeled as having an alcohol use disorder, or potentially we could be dealing with a tobacco use disorder or an opioid use disorder or a cannabis use disorder, et cetera, et cetera. But in general, rather than showing you these criteria again and again, I'm just showing you the general criteria because the criteria are ultimately the same for each disorder. The only difference is the substance in question. So in order to diagnose a use disorder, we need to be observing at least 2 symptoms spread over a 12-month period of time consistently. And in general, the symptoms spread across these 4 categories, although it's not necessary that we see any particular number of symptoms from any one of the categories. So first up, we may see symptoms indicating impaired control. So the substance may be taken in larger amounts or for a longer period of time than initially intended. There may be a desire or unsuccessful efforts to cut down. The person may spend more and more time obtaining, using, and recovering from the drug, or they may develop cravings. We may also see symptoms of social impairment, which could include recurrently using the substance, contributing to a failure to fulfill major role obligations, like being able to be an employee or a student or a spouse or a parent. We may see continued use despite having regular social or interpersonal problems. And we may see important social, occupational, or recreational activities given up because of the substance use. We may also see indicators of risky substance use. So this could be regularly using the substance in a physically hazardous situation or continuing to use the substance despite knowing that it's a problem. Finally, we may see pharmacological indicators of a problem, such as tolerance and withdrawal. Each of these is a 2-pronged definition. Tolerance is basically needing more of the substance to achieve the same effect or experiencing a decreased effect without increasing use. So we might see a person who previously smoked half a pack of cigarettes today, now they're needing to smoke a whole pack today, or if they do not increase their use, they're going to be feeling more jittery or less of an effect. Withdrawal would be a person who's experiencing physical symptoms due to substance concentration decreasing in the body. This is typically a consequence of prolonged or heavy use, and the symptoms of withdrawal typically depend on the substance, and we'll talk more about specific symptoms later on today. And so at the end of the day, the substance is taken to avoid symptoms. So in this case, the person isn't experiencing a high, so to speak, because they're using the drug. Instead, they're experiencing symptoms as a consequence of the drug not being in their body, and so the substance is taken to avoid those symptoms. In general, different substances can be categorized according to what it is that they do, and we'll sometimes use the term class or class of drug to describe these different categories. So different drugs fitting into the same category are in that category because they act on mood, behavior, and thought in the same way. So hallucinogens like marijuana, LSD, Molly, all alter sensory perception and induce visual or auditory hallucinations, and in doing so disrupt reality and thought processes. Stimulants like tobacco, caffeine, cocaine, amphetamines all increase alertness and energy by boosting activity in the central nervous system, or as you guys saw earlier in the instance of caffeine, by blocking chemicals that contribute to decreased alertness. Depressants, which include barbiturates, opiates, alcohol, anesthetics, and anti-epileptic drugs, dampen activity in the central nervous system, slowing thought processes and physical activity. Barbiturates more specifically block pain during surgery and help to regulate blood pressure and produce euphoria, whereas opiates, which we'll talk about a little bit more so later today, include morphine, heroin, codeine, and these are all derived from the opium poppy and mimic the body's natural opiates to regulate pain and pleasure. So they're mimicking the effect of endorphins in the body. There are several different models of addiction, so this is going to be the chunk of the chapter of the lecture where we focus more on theory. So each of these models is an explanation of where addiction comes from. So up first, we have the biomedical model. Per this model, unsurprisingly, dependence is viewed as a chronic brain disease. So this is not something that can be fully treated, caused by the biological effects of psychoactive drugs. So this could be any type of drug across any of the categories that we just discussed. At the end of the day, genetic vulnerabilities and chemical dependence are identified as the cause of addiction, and these are things that can be inherited. These can also be things that can be learned potentially through persistent use. And there is evidence for heritability of addiction in that there are high concordance rates among twins, meaning that if one twin is diagnosed with some type of addiction, it's highly likely the other twin will as well. Again, indicating a strong concordance, and we talked about that earlier in the semester in terms of reviewing those twin and adoption studies. So hopefully that's familiar information to you guys. In terms of what specifically is going on genetically, it kind of varies. There's not a single like addiction gene, but some people may inherit a tendency to kind of seek out thrills or positive effects, and also may inherit a tendency to disregard negative consequences. So those people may be more likely to really enjoy the highs and the positive aspects of use and to just kind of disregard or shrug off the more negative consequences. In terms of evidence for this model, so this model, which again is kind of the chronic brain disease model, saying that like you use a drug and it has a physiological impact on the brain, and that creates kind of this chronic situation in which you're addicted and you're needing the drug to help your brain function. Evidence for this comes from opiates, for instance. So opiates trigger dependence by suppressing the brain's natural production of endorphins, and so we become dependent because the brain's no longer producing this chemical at the same level, and so we're reliant on the drug for that chemical now. So opiates are a really clean-cut example that really adhere to this biomedical model. Criticism or evidence against is that some drugs, such as alcohol, don't act on specific receptors. This model also does a better job of explaining why an addiction problem would continue than the origin of the addiction. So it explains why you would need to continue to take opiates because your brain's production of endorphins is decreased, but doesn't really do a great job of explaining how we go from the first use of this drug to this state of dependence. The reward model does a nice job of explaining how addiction could emerge in the first place. So this is a nice model that kind of complements the biomedical model. So this model attempts to explain the initial motivation for repeated drug use, i.e. the pleasurable effects. So it focuses on the elements of drug use that are pleasurable and how that could encourage a person to kind of keep coming back for more, so to speak. So rather than focusing on specific neurotransmitters that may be impacted by drugs, things like endorphins, for instance, this model focuses more so generally on dopamine and that high or that rush that we get in our brain's reward system, and how that can kind of create this loop and this dependence and this pleasurable experience that contributes to people continuing to use and use again. Interestingly enough, this reward system in the brain is not exclusively activated by drugs, but it's activated by pleasurable activities in general, things like eating, sex, as I mentioned earlier, other things like exercise or gambling can activate this area of the brain as well. To such a degree that in animal studies, if given the choice between pressing a lever and receiving food, or pressing a lever and having the reward system of the brain be stimulated by electrodes, rats will frequently prefer the lever that activates their brain compared to the lever that would give them food. So this is an extremely reinforcing and strong area of the brain. Evidence for this model comes to us in the form of people who develop a dependence from one drug are more likely to become addicted to others. So, meaning that this person's almost gotten hooked on dopamine, so to speak, and so it's easy to transition from one drug to the next. Criticism for this model is that it doesn't really explain why addiction persists despite unpleasant side effects. So, for instance, overdosing or vomiting regularly or getting into financial or legal or interpersonal trouble. At this point, the drug's no longer really pleasurable theoretically, so why would use persist? A third model that I want to highlight is the social learning model. Per this model, addiction is viewed as a behavior shaped by learning as well as socio-cultural and cognitive factors. So this model kind of pairs really nicely with some of the other social perspectives we talked about in this class. For instance, the sociocultural theory of eating disorders. While different, is obviously another social model that says that this behavior comes from social influence. So basically, exposure to pro-smoking media increases smoking in adolescence. Smokers can also learn, so to speak, when to smoke. So there's a reason that there are these stereotypes and tendencies to, smoke after a meal or after sex or first thing in the morning or when drinking. That's not necessarily biologically programmed. It's something that we're kind of socialized to do through media. Um, Teenagedom is the prime time for such influence, since this is when self concept is developing and health behaviors can kind of be incorporated into that self identity. Fortunately, though, there is some evidence that social institutions can play a role in helping teens kind of steer clear of problematic drug use behavior. Specifically, social control theory says that teenagers with a strong sense of attachment to institutions, such as school, church, and family, are less likely to use drugs. On the flip side, though, peer cluster theory does tell us that if peer groups are strong enough to overcome the influence of such groups, that a teenager's behavior may change and start to mirror the peer behavior more so. Okay, so that's the end of our general intro info. So now we're going to shift into our 3 drugs of focus. Again, alcohol, tobacco, and opioids. And more specifically, we'll talk a little bit about like what each drug is. We'll talk about some biopsychosocial pieces, treatment pieces, things like that. The information is going to be a little bit different drug to drug, just what I think is kind of most important for you to know about each drug. So alcohol is a depressant. It works by increasing the firing of GABA in the brain. GABA is our brain's primary inhibitory neurotransmitter, meaning that when it fires, it kind of contributes to the brain powering down. So by increasing this inhibitory hormone or this inhibitory neurotransmitter, alcohol is directly powering down the brain, so to speak. Symptoms of intoxication or symptoms of use include slowed cognition, impaired motor skills, poor reaction time, sadness, impaired memory, poor judgment, visual and auditory disturbances as well. Symptoms of withdrawal include tremors, anxiety, irritability, agitation, cravings, insomnia, vomiting, headache, sweating, vivid dreams, and increased heart rate and respiration rate. So those latter symptoms would be symptoms from lack of use in someone who has developed dependence. Alcohol, though long-standing as our most popularly used legal drug, is interesting because although it's legal, it is one of only a handful of drugs that can potentially kill you via the withdrawal. There are many drugs that are, of course, are dangerous from an intoxication overdose perspective, but not many drugs have fatal withdrawal. So it's interesting that our one really popular legal drug is threatening in a way that some street drugs, some illegal drugs are not. So what happens if a person is going through this severe withdrawal? First of all, we'll see either hallucinations or seizures 1 to 2 days post-consumption. These hallucinations may even include something called a formication, which is a particular type of hallucination where a person feels this kind of creepy crawly sensation on their skin. Then 3 to 8 days post-consumption, the person will experience delirium tremens, which I'm sure is a term that many of you guys are familiar with. In order to formally diagnose this, we need to see 2 of the following symptoms: autonomic hyperreactivity, hand tremors, insomnia, nausea or vomiting, hallucinations, psychomotor agitation, anxiety, and tonic-clonic seizures. At the end of the day, 1 to 4% of people going through this process end up dying due to metabolic complications, and this estimate may be low as these numbers are based on only those who succumb in the hospital. Those specific complications include hyperthermia, cardiac arrhythmia, and seizures. Alcohol, along with opiates and benzodiazepines, are the drugs that do have those potentially fatal withdrawals. But interestingly enough, a potential treatment for fatal alcohol withdrawal death is going to be actually prescribing those benzodiazepines. One of the reasons that this is an effective treatment has to do with the principles of cross tolerance. Basically, what cross tolerance is it's when a person develops a tolerance to one drug, say alcohol, as a consequence of regular use, and unknowingly develops a tolerance to drugs of a similar class at the same time. So, because benzodiazepines are in the same category as alcohol, they're both depressants, even though persons never used a benzo before, they are building up a tolerance as they're drinking more and more alcohol. So because we know that in order to lessen withdrawal, we have to consume more of the drug, but in this scenario, we don't want to drink more alcohol because alcohol is what's causing the problem in the first place. What a physician will end up doing is prescribing a similar drug to lessen the withdrawal symptoms, in this case, a benzodiazepine, which, as I mentioned earlier, is a drug that's used to treat anxiety by increasing GABA, so increasing that inhibitory neurotransmitter to kind of counter the high energy of anxiety. And so Valium and Xanax would be examples of drugs that would fall into this category. This is a physician supervised process that would happen in the hospital. And ultimately, cross tolerance is a principle that can be applied to any class of drugs. There are several health consequences to alcohol use, most notably alcohol cirrhosis, which impacts about 10 to 15% of chronic users. This is basically when the liver begins to deteriorate and malfunction, requiring a liver transplant. And this is ultimately because the liver is our body's main organ responsible for filtering out toxins, including, of course, alcohol. Wernicke-Korsakoff syndrome is an interesting complication as well, impacting about 12.5% of users. This one's interesting because it's kind of an indirect complication. It's basically a thiamine deficiency due to malnutrition. So this would impact a consumer who's basically drinking at the expense of good nutrition and is now thiamine deficient. So symptoms include confusion, apathy, amnesia, ataxia, and this requires immediate corrective nutrition to fix. And unfortunately, about 80% of people don't recover, either because they don't know that this is what's going on and don't correct their nutrition, or in some cases, people do know what's going on but still choose to not correct. And so, unfortunately, even though immediate correction could reverse symptoms, without immediate correction, the symptoms will persist. And so, some folks end up having permanent amnesia and memory issues. And then finally, fetal alcohol syndrome is another complication. This is not an exhaustive list, just some highlights I wanted to hit. This would be diagnosed when a pregnant woman is consuming alcohol. The alcohol passes through the placenta as it's fat soluble and ends up harming the fetus. The highest risk drinking behaviors for a pregnant woman are binge drinking, which would be consuming 4 or more drinks in one sitting, and then in particular drinking during the first trimester, as this is when the brain is developing more prominently. Symptoms include facial anomalies, which are depicted on the image on the right side of the screen, growth retardation, and neurodevelopmental abnormalities, including poor fine motor skills, hand-eye coordination, and an abnormal gait. Later comorbidities that may be diagnosed as a consequence of FAS include learning disorders, impulse control problems, and substance use disorders. In terms of what's going on with alcoholism from a BPS perspective, biologically, there are genetics. As I mentioned earlier, some may inherit a greater tolerance for alcohol and its adverse effects, or a greater sensitivity to its pleasurable effects. Psychologically, temperament and personality may play a role in addiction, specifically those who are attracted to excitement, are intolerant of frustration, those who are more prone to deviance, and those who have a greater degree of negative emotionality are all folks that may kind of trend towards alcoholism. Psychologically as well, behavioral reinforcement and coping mechanisms may also facilitate alcoholism, meaning if a person is reinforced for drinking so they feel more socially accepted potentially while drinking, that can facilitate alcoholism. Alcohol can, of course, also evolve as a coping mechanism. Socially, alcohol may provide folks with a timeout, so to speak, from everyday life. It also may give people an opportunity to think less, particularly for worriers, or feel better about themselves if we're talking about a person who has a lower self-image. Another social piece is that people tend to drink more in particular settings, specifically large mixed sex groups and small same sex groups. So basically big parties or smaller girls' night, boys' night types of things. In terms of treatment, I always like to, anytime I'm doing any behavioral change, but particularly with alcohol, I like to hit that relapse prevention pretty hard, meaning just talking about that maintenance phase of the stages of change model, talking about how nobody's perfect. You know, if we're talking about the rest of your life, the likelihood of you never drinking again is very low. And so we just need to talk about what to do in the event of a lapse and how to get back on the horse, so to speak. Motivational interviewing can be a helpful process in terms of resolving ambiguity. Like, does a person really want to quit or not? And this can help us identify a person's stage of change and then use that stage to inform further treatment. So for instance, relapse prevention would be a good treatment approach if we were in the maintenance stage. Aversion therapy could potentially be used. An example of this would be Antabuse, which is a drug that when taken is going to induce vomiting and nausea when alcohol is consumed. Substitution could, of course, be used in dangerous situations. Benzodiazepines is the example I gave earlier, so that could be used to substitute in a physician-supervised arena to help prevent fatal withdrawal death. Antidepressants such as Prozac have also been shown to reduce cravings, although I wouldn't necessarily throwing one substance on top of another as the first line of treatment. Exercise can also be a helpful course of treatment for any type of substance use. Research suggests that it can temporarily reduce cravings, although it seems to be dose dependent, meaning that exercising will help to reduce cravings for, you know, the next couple of hours or so, but that you're going to need to re-up on your exercise regularly to continue to get that boost. Finally, 12-step programs such as Alcoholics Anonymous focuses more so on abstinence and social support. Testimonials tend to be positive, despite controversy over the religious emphasis, quote unquote. They say higher power, not specifically God or a Christian God, but the initial connotation of higher power, at least in this country, is, you know, God and Christianity. So you just can't get around the fact that that's going to turn some people off. There's not an evidence base to this approach. That's important to point out. It was basically established and created by two alcoholics who wrote down kind of what worked for them. So it's not empirical in nature. It's highly anecdotal. But at the end of the day, it is free, it's everywhere. And because of its reach, you know, even if it only works for a percentage of folks with alcoholism, it is worth talking about simply because of its reach and accessibility. Okay, moving right along to tobacco. Tobacco is kind of interesting in that it functions as a stimulant and a sedative at times. This is because it has an impact on two chemicals in the brain, epinephrine and dopamine. So dopamine facilitates tension relief and epinephrine facilitates alertness and concentration, which are the two main signs of intoxication. Symptoms of withdrawal include depression, insomnia, irritability, anger, anxiety, difficulty concentrating, restlessness, and increased appetite, and collectively withdrawal can last for about a month post last use. There are multiple methods of use which have created these interesting kind of subcultures, which is a unique piece, I guess, to tobacco use. So, you know, you've got vaping, cigars, you've got the socialized use, which is a really strong piece that kind of goes alongside tobacco specifically. Vaping, interestingly enough, has decreased cigarette use, so vaping typically gets a lot of praise for that reason. But at the end of the day, it's increased total tobacco use, particularly among young people. The legal age of use has also increased recently from 18 to 21, and this is something that happened on a federal level in 2019. There are many health consequences, of course, to tobacco use. It specifically is the largest preventable cause of death worldwide. Um, this is kind of a nice graphic that just kind of lists for you the various cancers, including lung cancer, that are impacted by tobacco use, and then other chronic diseases, including things like coronary heart disease, diabetes, even things like ectopic pregnancies that you might not necessarily think of. Another interesting health piece about tobacco use is that health experts are now discovering that a number of the disorders once thought to be the normal consequences of aging are in fact caused by long-term smoking. Specifically, some of the mental decline observed among elderly people may be caused by bleeding in the brain or silent strokes that go unnoticed over time. The hazards of smoking in this way seem to extend to those in the surrounding area as well. So it's not just impacting those who are smoking, but those in the area secondhand. Um, some estimates indicate that secondhand smoke may contain an even higher concentration of some of the carcinogens than when inhaled directly from a cigarette. So at the end of the day, as many as 49,000 deaths per year in the United States are a result of secondhand smoke. So some interesting kind of added pieces in terms of smoking's impact on aging and those who aren't even smoking, but are simply in the vicinity. So why do people smoke? Since the data around tobacco in particular is particularly bleak. A lot of it has to do with socialization, and this typically ends up proving to be the mechanism behind someone experimenting with tobacco in the first place. Either peers are smoking, or more typically these days, vaping, and it seems like something a person might like to try, or alternatively, it's something that seems appealing through media or advertising. A lot of the big vaping companies kind of came under criticism recently for really obviously trying to appeal to young people with really kind of poppy, punchy ads, or flavors that would obviously appeal to children more so than adults. So advertising and marketing plays a huge role in people beginning to experiment with tobacco at an early age, and then kind of developing a regular problem that persists into adulthood. Biologically, smoking ends up being maintained through dependence. So kind of going back to that biomedical model that we talked about earlier. Beyond that, there are also some psychosocial elements in that smoking helps people regulate their emotional states. Many people who are dependent on the drug have a difficult time kind of staying calm in situations, or just kind of regulating themselves over the course of the day without using. As far as treatment goes, culturally sensitive role models and campaigns are an important thing to recognize. And this is something we talked about a little bit earlier, even in just talking about general messaging, that people tend to respond more to messaging campaigns when they can see themselves in the campaign. So that means attending to the age of the role models and campaigns, but also the race, the culture, and to really try to target campaigns to particular groups versus a general campaign that's really not going to resonate with anybody. Relapse prevention, again, is very important here, particularly as far as tobacco goes, which is a highly relapsable drug. Few people are going to quit the first time. It can be important to talk about replacement behaviors like gum, nicotine-free gum in this instance, or candy, just something to kind of replace that oral fixation. Or you might consider a nicotine replacement, something like a nicotine gum or a patch or something like Chantix. Psychoeducation and support can also be effective prior to quitting, and we'll talk about that a little bit on the next slide. In a nutshell, there's no single treatment program that has proved to be the most effective. Most programs have a high relapse rate, but at the end of the day, there are a couple pieces of psychoed based advice that have kind of demonstrated themselves to be more effective. Specifically, some factors that seem to be key are deciding to quit, establishing a plan, developing strategies to deal with withdrawal ahead of time, so acknowledging that relapse prevention, that maintenance piece, and then maintaining success. So in terms of preparing to quit, it's important to select a specific day and eliminate cigarettes, ashtrays, vaping supplies by them to find a replacement. So this might be a nicotine-free replacement, something like a sugarless gum or a Lifesaver is what my grandfather used, something to kind of replace that oral fixation. I have one client right now who like special orders these toothpicks online that she really likes. They kind of have this minty kind of flavor. They seem kind of artisanal in nature, but she likes the taste and it kind of gives her something to do instead of vaping. Create a plan. Are you going to use nicotines? Or are you going to go so far as to look at like a nicotine type of gum or Chantix? And if so, make sure that you have that in place. Also get social support. Tell people that you're doing this to promote accountability. And then on quit day, avoid all smoking, all vaping, keep active, drink lots of water, and use your replacements if that's what you're choosing to do. Stay away from people and places that are triggers. So do not hang out with people that are vaping or smoking. Don't go to places where you would typically engage in those things. Try to stay clean, so to speak. If possible, attend some type of class or group promoting smoking cessation or vaping cessation. Follow any type of self-help plan that you've established, which might include counseling, or might include shifting your focus towards the things that you want to do that tobacco is maybe holding you back from. And then finally, we are almost there, I promise, opioids. So opioids have really kind of come onto the scene recently and become more and more relevant. In general, drug overdose deaths have increased fivefold since 1980, and as of 2009, drug overdose deaths have overcome motor vehicle deaths as being the more prominent way in which people die accidentally. So that's extremely significant, and opioids are really kind of driving that particular trend. In 1999, opioids accounted for about 30% of all overdose deaths, whereas in 2010, this number had doubled to about 60%. Morbidity has increased as well, so it's not just deaths, but overall impact on quality of life. We're seeing more and more emergency department visits, as well as infections such as hepatitis C, HIV caused by needle sharing, an increased number of falls in older adults, and a much larger number of babies being born with active opioid withdrawal. Opioid abuse costs the United States about $72 billion a year, which is comparable to the toll of asthma or HIV, for reference. In terms of who opioids are impacting, men tend to use at twice the rate of women. Men also tend to overdose more often, which is interesting given that women are prescribed the drugs prone to abuse more frequently. Rates of abuse tend to be highest among young folks aged 18 to 25. American Indians and Alaskan Natives and Caucasians report the highest rates of abuse and overdose deaths. And people eligible for Medicaid are more likely to be prescribed opioids and ultimately overdose. A lot of this has to do with coverage. More of these policies are more likely to cover these addictive painkillers compared to potentially more expensive, less addictive alternatives. The highest death and sales rates are in the Southeast, especially the Appalachia region where we live, as well as the Northwestern United States, so areas like Seattle and Portland. 50 to 80% of those dying from overdoses have a history of chronic pain. Mental health and substance use histories are also pretty common. So what are some of the drivers of this epidemic? So because opioids in particular, it truly is an epidemic in terms of the deaths, we're going to focus more on studying that trend versus the same kind of perspective that we took on alcohol and tobacco, for instance. So what are some of the things that are impacting this epidemic? One is the prescribing trends. We are seeing a larger number of opioid prescriptions, the amount of prescriptions written as well. So since the 90s, we're seeing more and more scripts for opioids, and the amount per script has increased as well. So more and more is entering the marketplace via pharmacies, basically. We're also seeing a trend with respect to high volume prescribing. So we're seeing a majority of these scripts coming from a few prescribers. So it's not that everybody's writing these, rather we've got kind of a handful of folks that are writing a large number of prescriptions for a higher and higher amount of drug per prescription. More of these prescriptions are also coming from general prescribers like primary care physicians or internists. So these are folks that aren't necessarily trained in pain management or addiction. So some of this prescribing may come from naivete and just kind of not knowing. Some of it also comes from pill mills, which are cash only unethical pain clinics, primarily a problem in Florida. So these are places that understand that they're writing prescriptions for addictive drugs. And that's kind of the purpose, is to write as many of these scripts as possible. They're cash only, they're not really going through insurance. The aim is to kind of maintain addiction and make money versus to treat. We're also seeing prescribing coming out of emergency departments. And this is tough because in an emergency department, a patient kind of checks in, whatever is going on is treated, and that's it. You may never see that patient again. And so prescribers in this scenario are unaware of full patient history. And so they're unaware if this is, the second or third emergency department this patient has been to this month. All they know is what is in front of them. Pharmacies are also problematic, and then this is ultimately where the large quantities of opioids are coming from, or the large numbers of prescriptions are coming from. And so this is a problematic area as well. Insurers also have a greater tendency to cover cheap methadone versus non-opioids. Methadone is actually a course of treatment that can be helpful for addicts in that it supplies the same effect that you're getting from an opioid, but without the psychoactive element. So it is a good treatment option for people who are actively addicted. But in general, insurers tend to cover cheap addictive options more so than less addictive options. We also have high-risk patients that are contributing to the problem. These are a small percentage of patients who receive a large number of the total prescriptions. So people that are getting prescribed the drugs again and again and again, kind of like the high-volume prescribers. Opioids are then sold or dispensed to others without a prescription. So we kind of start with this legal access, so to speak, which then becomes illegal access. As of 2010, enough opioids were sold to give every United States adult a 5 milligram dose every 4 hours for a month, which is a staggering number. And this is just kind of legal through the pharmacy opioids. This is not including street drugs, which people typically end up transitioning to eventually because they're cheaper and easier to access than medications like Oxycontin. So people typically begin in this arena and then end up transitioning to heroin or fentanyl, some type of drug that's easier to access. A lack of public education is also a big piece of it. 70% of people who have used a pain reliever non-medically got it from a friend or a relative. So people just not really realizing the stuff is addictive, and maybe just giving someone a pill or two because they're in pain without really kind of thinking through the process that this can become addictive. Lack of proper storage or disposal of unused or old medications. So any old or unused medications should be returned to the pharmacy, not flushed or thrown out because it's going to get into the ground, soil, and water. But not storing stuff can set it up to be stolen or potentially sold later down the line if finances become stressful. But the vast majority of people who end up becoming addicted didn't kind of seek this drug out to become addicted. A lot of times it was prescribed for some reason or given for some reason, typically pain, and without kind of knowing how addictive it can be, it just gets out of control. Yeah. In terms of treatment options, public education is obviously one route we can take. Just because it comes from a pharmacy doesn't mean that it's safe. These drugs are really extremely dangerous. Certain drugs, particularly opioids, are easily abused, so be extremely careful when taking these drugs. Never share prescriptions, and then properly store of and dispose of old medication. Prescriber education is also important since this is kind of the gateway, so to speak. This is kind of the access point where most people end up developing a problem that then leads to the use of street drugs down the line. So we need an increased number of medical school classes in pain and addiction to kind of make sure that everybody is well versed in this, not just pain specialists. Ideally, there would also be changes with respect to the pharmacy process. So pharmacists not dispensing medication if there are signs of abuse. or being aware of the number of prescriptions a person has and potentially being able to deny access if the person's coming in with scripts for multiple emergency departments, for instance. It would also be great if insurers could reimburse for healthier options. As far as use goes, there are a number of nonprofit programs that are aimed at providing people with clean needles and supplies. Um, Safe injection sites, or helping to reverse overdose with naloxone. These are fairly controversial approaches, I would say, in that the greater tendency around drug use in general, including opioid use, is to criminalize it and punish it. And there are definitely folks that view these perspectives and approaches as kind of enabling the problem, so to speak. But at the end of the day, these folks who are addicted, didn't choose this. And this is an extremely addictive drug, one that's very, very difficult to quit. And so if people are using the drug, it makes sense to try and keep people alive and help them be safer. And research suggests that if you are helping people regularly with safe injection sites, places where they can go to shoot up or use a drug in a safe, supervised environment with professionals who can um, give those overdose reversing drugs and not call the police. Research suggests that those people are more likely to access a rehab program willingly than if you're just kind of forcing it or using exclusively punitive approaches. Alternative medication can also be an approach. Medication assisted treatment is the term that's typically used. So methadone would be prescribed and a person would use methadone to kind of avoid withdrawal and kind of stay stable without that psychoactive element. So those are some treatment options. Alrighty, I know that was a long one. Thanks for hanging in there with me. That is all that I have for you guys today.